Okay, the time has arrived, so we might as well begin the session. My name's Peter Engel. I'm from Christ Hospital, Cincinnati. I'm here with Dr. Rich from Northwestern University Medical School, Feinberg Medical School, and Fran Rogers from Temple in Philadelphia. We're going to talk about a subject that might not seem relevant to patients with pulmonary arterial hypertension, PAH, but believe me, it's quite relevant to every patient that is here today for a number of reasons. I'm going to cover a few points in general about the topic of PH associated with left heart disease. We call it the great masquerader because it's sometimes difficult to distinguish from other forms of pulmonary hypertension. In fact, it's extremely difficult at times. The first job of any physician or nurse taking care of patients with pulmonary hypertension is to accurately classify that patient in terms of the 5 groups that I'm sure you're all familiar with. Just to review them, Group 1 is PAH with various subtypes. Group 2 is what we're talking about, pulmonary hypertension associated with left heart disease. Group 3 is pulmonary hypertension associated with hypoxemic lung disease. Group 4 is chronic thromboembolic pulmonary hypertension, a very important group. And Group 5 is patients with PH with multifactorial causes such as sarcoidosis. What you may not know is that these groups overlap to a great extent, and one of the most difficult problems is distinguishing between Group 1 and Group 2, that is PAH versus what we're talking about today, PH associated with left heart disease. And if you've attended any of these sessions here in the last few days, I'm sure it hasn't escaped you that it's virtually impossible to evaluate a patient for pulmonary hypertension and with pulmonary hypertension without doing at least right heart catheterization, if not right and left heart catheterization. So necessarily what we'll be talking about today will involve some terms relating to heart catheterization and pressures and resistances and flows. We'll try not to be too technical about it, but it's unavoidable to speak about catheterization since it's an essential part of any evaluation of a patient, as far as I'm concerned, with shortness of breath. The reason it becomes important is because the distinction between Group 1 and Group 2 is dependent upon a certain measurement at right heart catheterization called the wedge pressure. The wedge pressure is the pressure that we obtain from the catheter tip. It's in the right heart, it's in the pulmonary artery, it's advanced as far as possible into the pulmonary artery until it wedges into position in a small pulmonary artery and thereby records the back pressure from the left heart, basically the left atrium. The left atrial pressure or the wedge pressure is something we're very, very interested in classifying patients accurately. The left atrial pressure is reflective of the left ventricular filling pressure or diastolic pressure. And we're going to talk about diastolic dysfunction in a minute since it's the most important cause of pulmonary hypertension. I might add that the most common cause of pulmonary hypertension in general is PH associated with left heart disease. And that's one of the reasons that it's so important to you and all other patients with pulmonary hypertension. On right heart catheterization, what's been found, I just was looking over an article that was recently published showing that in patients who initially looked like they have PAH, Group 1 pulmonary hypertension, studied at right heart catheterization and given 500 cc's of saltwater saline solution. What looks like PAH to begin with turns out to be PH associated with left heart disease. It has several other names. Diastolic dysfunction is one of them. Pulmonary venous hypertension, PVH, is another name that it goes by. So in that study, 20% of patients who were initially diagnosed with PAH turned out to have PVH, pulmonary venous hypertension, PH associated with left heart disease after given a fluid bolus, 500 cc's over 5 to 10 minutes. We did a similar study in patients who were initially classified as Group 1 PAH with exercise. Again, 20% to 30% of patients turned out to have markedly elevated wedge pressure, left atrial pressure, left ventricular filling pressure, and were reclassified as pulmonary venous hypertension. In addition, if you do left heart catheterization in addition to right heart catheterization and directly measure the pressure in the left ventricle at the end of diastole, the left ventricular end diastolic pressure, we find that up to 40% of patients with PAH have been misclassified and are actually patients with left heart disease causing pulmonary hypertension. Making it even more confusing is the fact that many patients with pulmonary hypertension are treated with diuretics, are kept NPO, nothing by mouth, before their right heart catheterization. As a result, they can be volume depleted, meaning the amount of fluid in their body is low. The wedge pressure, the filling pressure of the left ventricle will be deceptively low. And when you rehydrate those patients, it turns out that they may well have pulmonary venous hypertension. So overall, I would say it's a fair statement to say that 20 to 30% of patients who are initially classified as pulmonary arterial hypertension turn out to have PH related to left heart disease. And this becomes important because of what Dr. Rich is going to discuss, namely the treatment of PVH or PH associated with left heart disease.
Couple questions. Is it common for someone to have PAH for, say, 15 years and then be diagnosed with PVH after that?
No, it's not common. 15 years
Yes.
of treatment for PAH?
Yes.
It's pretty unlikely.
I have it 6 months ago.
It happened to you?
Yes.
You were diagnosed with PAH for 15 years, treated for it for
Yes.
15 years?
Flow-Lantriclear and now sildenafil.
An unusual experience. So what happened to your treatment? Was it stopped?
I was weaned off of Flolan after 4 years. That was the only treatment back then in '98. And then they put me onto Tracleer. And when they found the PVH, they said that the Tracleer would be hurting the PVH. Not hurting, but you know. And so he switched me to sildenafil.
Okay. Well, Dr. Rich is going to talk about that treatment in a minute.
Awesome.
But go ahead.
And then my next question was the wedge pressure, you said significantly elevated. What is normal wedge pressure compared to elevated wedge pressure?
Normal wedge pressure actually is less than 10 to 12 millimeters mercury. But the diagnostic criterion for PVH is a wedge pressure greater than or equal to 15 millimeters mercury. We often see patients in the 20s and even up as high as 30. I might add that, well, no, let's not confuse matters further. But one thing I would like to say is that just because you have PVH doesn't mean you're immune to PAH, and vice versa. So it becomes even more confusing. And this is why this is such an important thing for you to be hearing about. So our next point was to list the types of left heart disease which can be associated with pulmonary hypertension. That is the general term PH, not PAH. So probably the commonest is left ventricular diastolic dysfunction, which again goes by several different names, confusing both physicians and patients. HFpEF is a common name that physicians like to talk about. Heart failure with preserved ejection fraction is also left ventricular diastolic dysfunction. Pulmonary venous hypertension, as we already said. Left ventricular systolic dysfunction is a different entity, but is commonly associated with PH. These are patients who have low ejection fraction of the left ventricle, poorly performing left ventricle. This is not quite as difficult an area since it's very easy to identify patients with left ventricular systolic dysfunction by echocardiography and other means. So we can evaluate the ejection fraction, and it's very rare that patients with a low ejection fraction are confused for patients with pulmonary arterial hypertension. Valve disease is a very tricky area for physicians, not so much for patients. I think that one type of valve disease that's fairly commonly associated with PH is aortic stenosis, and certainly mitral stenosis as well, mitral regurgitation and aortic regurgitation, less commonly associated with PH. In my view, the general solution to treating patients with valve disease and PH associated with valve disease is to fix the valve problem, and in general, the pulmonary hypertension goes away. So this is a form of at least treatable or almost curable pulmonary hypertension. Now, patients with diastolic dysfunction, or HFpEF, fit a certain clinical profile, namely they're older, they're female, they're heavier, they have more hypertension, systemic hypertension. and more diabetes mellitus. And they're commonly in atrial fibrillation. And I've generally said that atrial fibrillation is a pretty rare arrhythmia to experience in a patient with pulmonary arterial hypertension, but it's fairly common in patients with pulmonary venous hypertension or diastolic dysfunction. So that clinical profile alerts the physician to the possibility of diastolic dysfunction, HFpEF, and PH associated with left heart disease. I would be against making that diagnosis on the basis of that clinical profile alone. Again, it's virtually impossible to assess a patient with PH or for PH without right heart catheterization.
Okay, I know Alex just said that she was told after 15 years, so I'm kind of similar. When I went to the specialty center and they did an echo, and this is my kind of question, is from an echo, can they have a good idea that there is diastolic dysfunction? I mean, I know I still have to get a cath, but from the echo, they're telling me that, 15, 16 years later, after the PH, this is what they're seeing.
I'll answer that question, but again, I'd make the point that patients with PAH are not immune to diastolic dysfunction, nor are patients with diastolic dysfunction immune to PAH. I'll give you the answer to your question just in my opinion. Others may have different opinions, and I don't want to monopolize this discussion. The one feature on echocardiogram that really alerts a physician to the possible presence of diastolic dysfunction is enlargement of the left atrium. Enlargement of the left atrium is a result of long-standing elevated filling pressures or diastolic pressures in the left ventricle. Of necessity, the left atrium has to dilate over the years. And I'm always watching for left atrial enlargement on echocardiogram. But to answer your question directly, I'm just going to give you my opinion. Others may have different opinions. I don't believe that it's possible from echocardiogram alone to make a firm diagnosis of diastolic dysfunction. We have various parameters that we can use to evaluate diastolic function, tissue Doppler imaging and the like. We can make measurements, but we cannot really do it without cardiac catheterization. We certainly can be focused on the left atrium and can be alerted to the possibility of diastolic dysfunction from echo, but I would never base the diagnosis on echo alone. That's just me. I don't know if the others have any different opinions. We have Dr. Rich here and Fran Rogers from Temple.
Well, I think the echo is at best a good screening tool, and I think we use that in PH as well, but I think clearly the diagnostic standard, gold standard is catheterization. Would you agree? Yeah.
Absolutely.
Me again. Do you have to have a left heart cath, or can they do it from a right heart cath to diagnose the diastolic dysfunction?
You don't have to have a left heart cath. I think that a lot of centers, this is really dependent on where you're studied from center to center. Some places do left heart cath routinely with every right heart cath. I don't think that's standard practice anymore. I think it's very useful to have a left heart cath to directly measure the left ventricular end diastolic pressure, to look at the coronary arteries, to assess valvular function. But it's not absolutely essential because the wedge pressure is a measurement made on right heart catheterization. Having said that, one of the real problems that we encounter, or should I say challenges that we encounter, is that even among experienced cardiologists, sometimes wedge pressures are recorded inaccurately. And when they're recorded inaccurately, they're always recorded inaccurately in the upward direction. It's virtually impossible to get a falsely low wedge pressure. But falsely high wedge pressures are the order of the day. We see it all the time. I have a slide that shows a collection of falsely abnormally high wedge pressures leading to completely incorrect diagnoses. So the right heart catheterization has to be done by a physician who is conversant in this field, who is experienced with hemodynamics and who understands what a good-looking accurate wedge pressure looks like and what an inaccurate wedge pressure looks like. And if the physician has any suspicion that the wedge pressure is inaccurately high, then left heart catheterization is next to measure left ventricular and diastolic pressure directly. So we've talked a lot about diastolic dysfunction, and I've asked Fran Rogers of Temple University to help us translate this notion of left ventricular diastolic dysfunction into everyday English language, which is a lot easier than it sounds. It's something I try to do daily with my patients, and I fail on a regular basis because it's a tricky concept, but Fran will help us with that. Fran?
Thanks. Yeah, so I've been charged with that, and I gave it some thought, and in my mind, I just think a picture paints 1,000 words. So I came up with a little schematic. I know we're not supposed to have slides, but I kind of drew this out, and it looks like my grandson Liam did it, and he's 4. But he, I'm sure he would probably be happy that I mentioned his name. But anyway, I think, as Dr. Engel said, it's really important to remember that left heart disease raises that left atrial pressure, and if it does it sufficiently and for over a long period of time, and it really isn't treated, then we're going to see that whole passive congestion back all the way up, and we're going to see it on the right side of the heart. So simply put, this is what I drew. So I drew it bigger, so maybe you guys can see it. So on the left side of the heart, again, when the pressure increases here, again, that left atrial pressure that we can look on an echo and see, wow, that left atrium looks really big. What happens is, again, if it goes untreated, then it just passively heads over to the right side of the heart. So there'll be increased pressure in the pulmonary veins, and then in the pulmonary capillaries. Then it's going to head over to the pulmonary arteries, and guess what? Next to see that is the right side of the heart. So that's sometimes how we see it may show up on the right side of the heart because it hasn't really been controlled or treated appropriately on the left side of the heart. So it gets a little tricky. We have to be very careful when we evaluate our patients. Sometimes it's very pure, sometimes it's mixed. But again, it comes to be a little bit of a diagnostic challenge. And I would think you guys would agree, you don't often get one pill to say, okay, we're done, we're good. We accomplished what we wanted.
Just one point I would make. I think it's important to think of the circulation as being in series. In other words, blood flow is in a straight line going from the right side of the heart through the lungs into the left heart. And if you think of it that way, you can understand that anything that's happening downstream, any kind of roadblock downstream, as Fran was describing, any kind of dam that a beaver builds in a stream that's flowing in one direction is going to have effects upstream all the way to the pulmonary artery in this case. Any questions about that as you look at the diagram? So we'll ask Dr. Rich to give some comments about treatment of pulmonary hypertension associated with left heart disease with drugs and other methods.
Thanks. Yes, I've been charged with telling you how we treat this disease, and in fact, if I had the exact answer, none of us would be here today, right? Because no one would have it. But no, in reality, as frustrating as this disease can be, both diagnostically and from a treatment perspective, both for physicians and patients, I do think there are some general principles and general approaches that we can talk about that I think are generally helpful when you have pulmonary hypertension from left heart disease. As has been mentioned now over and over again, I think one of the important things is to, again, step back for a second and first understand why somebody has pulmonary hypertension in left heart disease, because then that helps you sort of approach the problem with how to treat it. As was mentioned, in patients with left heart disease who have high pressures in the left side of their heart, to some extent, you have to have pulmonary hypertension of some degree. Now, oftentimes it's very, very mild or perhaps borderline, and it's trivial from a clinical perspective. But in other words, in order for blood to get from the right side of the heart to the left side of the heart, if there's high pressure on the left side of the heart, as Fran's diagram is showing, pressures need to go up in order to overcome that. It's like putting your thumb on a hose and causing a kink, or having a problem in a pipe and stuff backs up. And so if you decided to try to treat the pressure elevation, you haven't really got into the root cause of the problem, okay? So I think with that in mind, then you say, okay, how do we treat the root cause of the problem? And as Peter nicely illustrated, it really depends on what the problem is. And so if you had a big heart attack, and now the left side of the heart isn't working very well, well, there are a bunch of therapies that you use to treat the left side of the heart to try to make it stronger, to lower the pressures, and that will oftentimes help. If you have a valve problem, you can fix the valve, and the pulmonary hypertension will also go away because the pressure on the left side of the heart has come down. If you have blockages in the arteries around the heart, and you open up those blockages, again, the left heart is now healthier and happier, pressures go down, pulmonary pressures go down. But then you get to the entity that I think a lot of us are frustrated with, which is that diastolic heart failure, the HFpEF, the one that we all sort of throw around these terms. And, you know, in some respects, group 2 pulmonary hypertension or pulmonary hypertension from left heart disease is a syndrome that starts to develop in many respects as we get older. Because as we get older, we start developing higher blood pressure and perhaps diabetes, and we gain some weight and develop things like sleep apnea and all of those things overlapping, which causes pressure to go up on the left side and to cause pulmonary hypertension. So in the typical patient who would have high blood pressure and fluid now backing up and into the ankles and things like that, we treat them principally with medications that will lower that blood pressure, okay? Typically in PAH, it's the last thing we want to do, which is lower blood pressure in the body, okay? But if you have high blood pressure, we'll give you, there's a whole bunch of medications that we can prescribe that will lower blood pressure. Diuretics to get rid of the excess fluid and pressure is oftentimes effective as well. If you develop something like atrial fibrillation, then oftentimes we can actually treat the atrial fibrillation. There are medicines or even procedures that can be done to put the patient back from an abnormal rhythm to a normal rhythm. And restoring that normal rhythm can oftentimes thus lower the pressure on the left side again, and then secondarily lower the pressure in the lungs. If somebody does also have overlapping syndromes like sleep apnea or we've gained weight, then certainly I prescribe weight loss, not necessarily weight loss drugs, but weight loss concepts like which is always easier said than done. But the treatment of sleep apnea, because oftentimes you have to actually take a multi-pronged approach. It's not oftentimes one problem that has caused the quote-unquote diastolic heart failure, but it's an accumulation of things. We've got a couple of people in the audience here who have now described their personal experiences of once being told they had PAH, now being told perhaps they have a secondary form of pulmonary hypertension. And while I would agree that that is generally uncommon, in theory, if you were very fortunate and had a very successful run of treatment for your PAH and you went from being 40 years old to 60 years old, it is certainly possible, I guess, that at that point you also could start to develop features that we see in other people who are simply getting older. Like with most diseases, if I could give you one piece of advice in terms of how to avoid that disease, it would be to pick your parents wisely. Okay. I think probably genetics play a role in terms of sort of what ends up happening to us, but since, to my extent, we aren't able to quite do that yet, we're left with these generalized approaches. So group 2 or secondary pulmonary hypertension from left heart disease is, as Dr. Engel mentioned, by far and away the most common cause, in part because left heart disease is so common, okay, of pulmonary hypertension. It can be very, very confusing. I'd also just simply like to reiterate which was said. I think that the stakes are simply too high to misdiagnose these disorders on the basis of surrogate type, markers. So, someone looks at an echo and says, it kind of looks like left heart disease, PH, so we'll call it that, or it looks like PAH. I mean, I really do agree firmly. You got to get to the bottom of it. And if you do the right heart catheterization and that pulmonary capillary wedge pressure is, the tracing looks a little iffy or you're just not sure. In my practice, for the first cath, I almost routinely will put a special catheter into the left ventricle to directly measure that left-sided pressure if I have any doubt again, because I just want to make absolutely sure that I don't misclassify the patient, because the ramifications, of course, are significant because the treatment approach. Finally, I'll end my formal part of this presentation talking a little bit about, well, let's just say we've done all of those things. We've done the blood pressure lowering and the diuretics to get rid of the excess fluid, and we're exercising, we're losing weight, and you still have high pulmonary pressures from left heart disease. What about all the drugs out there on the market, right, for PAH? Would these drugs be effective in this disorder? And the simple answer is, at the moment, it does not appear that these are drugs appropriate for that condition. They have been studied, actually back several years ago. The hope and thought was perhaps things like Flolan or medications like Bosentan might actually treat pulmonary hypertension with left heart disease. And unfortunately, those trials were negative trials. In fact, in some of them, there was a concern that perhaps they could even cause harm to some extent. So the medical community kind of got away from it, and then more drugs came on the market, like was mentioned earlier, sildenafil and other drugs. And so those are sort of being re-looked at again in hopes that perhaps there may be a role for them. But at the current moment, that would be the type of thing which, if your physician decided to treat you with one of those, and you did have secondary pulmonary hypertension and left heart disease, I think that would be a specific conversation between you and your physician, and you may have a particular scenario that you and your doctor think, let's give this a try, with a caveat that, if you don't feel better, you get worse, we should probably stop that pretty quickly, okay? But there are some scenarios that I think, because the science of medicine is great, but I think all of us appreciate the art of medicine, and that every patient is different, and it has to be approached sometimes just a little bit differently. So I'll leave my part there, and I would also be happy to address any questions any of you might have. I think there's a question up here in the front.
Can you talk a little bit about diagnosing restrictive cardiomyopathy?
Sure. So the question was talking about restrictive cardiomyopathy. And so restrictive cardiomyopathy would lump into a form of diastolic heart failure. And sometimes the terminology can get confusing. Sometimes you can have what sometimes we refer to as restrictive physiology, and not necessarily restrictive cardiomyopathy. But cardiomyopathy, of course, well, not of course, but cardiomyopathy means a problem with the heart itself. There's a problem there. And the causes of that entity can be varied. Sometimes you can develop a process where something abnormal gets into the muscle of the heart. As we get older, things called amyloidosis. You can actually have things like sarcoidosis or other things that get into the muscle of the heart, making it very, very stiff. Think about when you go to a birthday party and somebody says, hey, would you blow this balloon up for me? You know those party balloons where you're like, oh, it's really, really hard to blow up, right? Those kinds. That's how you should think of restrictive cardiomyopathy, that very, very difficult to fill, not necessarily difficult to expel the air out, okay? But very difficult to fill. So I would think of restrictive cardiomyopathy on the spectrum of diastolic heart failure to be pushed over to this side where the heart is particularly stiff. And in contrast to the typical types of things that cause diastolic heart failure, high blood pressure and those entities, oftentimes those characteristics are not present in somebody with restrictive cardiomyopathy. So, that can be a very frustrating entity as well. But in terms of diagnosing it, sometimes it's fairly apparent in combination between the echocardiogram and the catheterization. Sometimes you have to do some sophisticated type of testing during the catheterization with multiple catheters, comparing, contrasting left heart pressures, right heart pressures. What happens when you take breaths in and out? Because just remember, the right side of the heart and the left side of the heart, they share a single space to some extent. They're covered by a sac called the pericardium, and they're divided by what we call the septum, okay? And so what happens on one side can affect the other side. So restrictive cardiomyopathy can be a bit tricky and challenging, but I think under the right conditions and the right hands, if you go through it systematically, you should be able to make the diagnosis. And then the treatment, though, sort of depends on why you have the cardiomyopathy, and if it's unclear, it's sort of the same principles that we've been talking about.
It's a very difficult diagnosis to establish, and it is something that echocardiography can be very helpful with. I'd certainly agree with Jonathan's distinction between restrictive physiology and restrictive cardiomyopathy. Restrictive physiology means there's severe diastolic dysfunction. That's something that we can tell from the echocardiogram. A restrictive cardiomyopathy is rare and is often associated, as Jonathan said, with an infiltrative process, something where the myocardium, the heart muscle, becomes infiltrated with an abnormal substance or with scar tissue. It's extremely rare. It can happen with excessive radiation or with amyloidosis, as you mentioned, or it can be idiopathic. The prognosis is not good, and the treatment, generally these patients, if they truly do have restrictive cardiomyopathy, are not very responsive to diuretics. Having said that, I recently saw a patient whom I diagnosed with restrictive cardiomyopathy 18 years ago and saw her again after 10 years, and she was doing fine. So my diagnosis was in error. This was a patient with diastolic dysfunction. Right and left heart catheterization is essential. We look for close to equalization of the pressures during filling of the heart on the right side and the left side. We sometimes resort to endomyocardial biopsy, which is a fairly benign procedure considering the fact that heart transplant patients get one sometimes every week to every month. It's something that's pretty easy to do and sometimes very, very revealing. But it's a tough diagnosis to establish with certainty. And prognosis is not good, and aggressive therapy needs to be done. I also want to say that the balloon analogy is a very important one, the one that Jonathan brought up, and I think we should have brought it up when we talked about diastolic dysfunction. That applies to all diastolic dysfunction, this stiffness of the heart muscle, which is comparable to trying to blow up a thick-skinned small balloon as compared to a thin-skinned balloon, is a good way of understanding what we're dealing with in the left side of the heart that has its manifestations in the right side of the heart, including pulmonary hypertension.
Did I understand you to say that the restrictive cardiomyopathy can be caused by radiation?
It can. It causes scar tissue to collect in the myocardium. It can also affect the lungs. Scar tissue can collect in the lungs as a result of radiation for example, Hodgkin's lymphoma.
I was very intrigued when my doctor talked about exercise and cardiac remodeling. I have a stiff left heart, and I know that with right heart failure, you can do some cardiac remodeling once you address the problem, but I wondered if you could talk about that.
Well, remodeling is a kind of a confusing term. We hear it a lot. I sometimes wonder whether it's a good thing or a bad thing to have remodeling. In general, when I hear about remodeling, I'm hearing it as a negative term. But you're asking about getting better with exercise. And we used to say in all forms of pulmonary hypertension that exercise is a no-no. There are some studies that have come from Germany and elsewhere that show that even in patients with the most severe PAH, exercise can be a good thing, can increase the 6-minute walk distance, can improve functional capacity. So exercise is no longer a no-no. As far as remodeling your heart by exercise, I'm not sure that that's really a possibility or something that one could realistically expect. One point I didn't make about diastolic dysfunction and this condition in general, PH with left heart disease, patients with this condition are just as limited, just as dyspneic, just as short of breath as patients with pulmonary arterial hypertension. So I think it's always a good idea if the patient's capable of doing exercise to get into an exercise program. It's almost never been associated with a negative outcome. I don't know about remodeling, but it's usually a good thing. Any other comments?
I'm a big fan of exercise with the principle being you listen to your body. So, I think you start gradually. I do think that we can it's a very vicious cycle where you can become very deconditioned because you think you can't exercise or you can't do anything, so you basically stop doing things and you're sitting around being very sedentary. And then when you do try to do something, you're short of breath in part because of your disease, but in part because you're also deconditioned. And again, it can be a very vicious cycle. And so I do think that exercise to an extent that your body tells you is okay is a good thing. Even insurance companies are now starting to reimburse and cover some forms of cardiac rehab in left heart failure, where previously they didn't, because now finally there is some emerging evidence that might be favorable. I would agree that the term remodeling can be confusing. Sometimes we use the term reverse remodeling because remodeling, as Dr. Engel mentioned, might be associated with actually not a good process. But I wouldn't focus so much on the actual remodeling, but really more just generally, strengthening your body, your muscles, your circulation, all of that is a good thing.
Yeah, I would agree as well. With our patients, we always have that discussion. It's like that commercial on TV, bodies in motion tend to stay in motion. So we recommend walking. You know how to do it. You don't need special clothes. You don't need special shoes. You always, again, have to listen to your body. Start with 5 minutes out, 5 minutes back, but do it most days of the week. It should be something that becomes part of your life. But that whole deconditioning thing is, it's something that you kind of have to be conscious of every day and work on it every day. But again, always listen to your body.
Okay, so is it normal for wedge pressures to increase with exercise?
Yes, is the answer. It never goes down. It doesn't stay the same. When I hear of an exercise cath study where the wedge pressure didn't change with exercise, I think it's probably inaccurate. Now, the real question is, to what degree is it normal for the wedge pressure to increase with exercise? And that's a tricky one, and there's no consensus in the literature. When I reviewed the literature on this subject, what I found was that the number which made the most sense was that normal individuals, healthy individuals, should not raise their wedge pressure to more than 20 millimeters mercury with intense exercise.
Okay, I went from 21 at rest to 30 with exercise.
Well, that's abnormal at rest and with exercise.
My daughter takes a fistful of vitamins every day. What's your take on vitamins? She wants me to take them, but I don't. I'm scared of them. So I've tried it and it had bad effects. So what's your uptake? Should you break into it slowly or not break into it at all?
I'm a skeptic, so I better not comment. Maybe the others would like to talk about it.
I'm a bit of a skeptic as well, but I will comment. Vitamins, it's like saying I take, medicines. I mean, vitamins come in all shapes and sizes, and you have to be extraordinarily careful when you take a vitamin. In this country, we're blessed that we have fortified foods. It's uncommon if you're eating a healthy diet that you're truly significantly deficient in most things that our bodies need. Having said that, sometimes people, for a variety of reasons, can become iron deficient, or, we know that pregnant women need extra folic acid, things like that. So on a person-to-person basis, there may be supplements that are important to consider in discussion with your physician. But to walk into one of those GNC stores, man, you can come out of there taking 12 more pills and having no more money. And for both those reasons. And then finally, I think what's underappreciated is when you come to see your doctor, I don't know if this happens to all of you, but when I ask patients and I review their medicines, they oftentimes forget to tell me all of these supplements that they're taking. And not only can some of them have some significant effects on your body, both favorably but also unfavorably, but they also can interact with the other medicines that you're taking. One of the hats that I wear when it's not a pulmonary hypertension hat is actually a heart transplantation hat. And some of the medicines that we give patients for heart transplant, anti-rejection drugs, there are many, many medicines that will interact with those medicines and cause the levels to go high and low and things like that. So I think you have to be very, very careful in terms of what you put into your body and discuss it with your doctor.
Yeah, I would agree. Absolutely.
I agree too.
I was told about 20 years ago, before I started having symptoms, that I had
an extraordinarily thick left heart wall and a very stiff left heart wall. What might this be? And it was shortly thereafter that I started having symptoms.
Well, that's the condition we've been talking about, is the diastolic dysfunction, HFpEF, pulmonary venous hypertension. The thickness of the heart muscle is called hypertrophy. It comes often as a result of long-standing systemic hypertension, and that can lead to stiffness, just as a bodybuilder becomes muscle-bound because his muscles become so thick and he can't extend his arms the way he should. The heart becomes somewhat muscle-bound and stiff, and that leads to all the things we've talked about here, including pulmonary hypertension due to left heart disease, group 2 pulmonary hypertension. You've been treated for PAH?
No.
Lisa? Oh.
No, I'm not taking anything except the calcium channel blocker.
Well, most physicians who are not in the field, not involved with PH, are not really
I've had pulmonary specialists since 2002.
right. But the pulmonary
Oh.
specialist is not a PH specialist.
No, they are PH specialists.
Oh, they are
Yeah.
PH specialists. Well, the distinction needs to be made to
Yeah,
every
okay.
single patient. It's
All right.
extremely important.
This is more of a general question for you as practitioners in the specialty centers. I know you said a big part of your initial consultations are to accurately diagnose or classify, but when you get a lot of referrals, especially with the ease, I guess, of availability of some of the newer drugs, do you get a lot of patients that maybe are being treated inaccurately? And then if you send them back, are you managing these patients long-term, or do you send them back to their cardiologists with recommendations, and do you find that that's overwhelming your practice?
I hold on to them for dear life, personally. I think that that's a very, very important question. And I think that anybody that treats pulmonary hypertension in any volume is going to see a large proportion of patients who have been put on drug without appropriate workup, including right heart catheterization, based on echocardiographic observations or clinical observations, et cetera. It kind of brings us back to the point we were making earlier about, that Dr. Rich was making earlier about treatment with PAH drugs, the 12 approved drugs for PAH in this condition of left heart disease. There are no FDA-approved drugs for treatment of PAH associated with left heart disease. And so anytime a patient with this condition is treated with those drugs, it's on an off-label basis, meaning it's not in the indications, and it's basically should be on an investigational basis, but at least on a provisional basis. But yes, we see a number of patients treated in the general medical community with PAH drugs who do not have PAH, who have PVH. And I think there are exceptional cases. I've seen them. I'm sure others have seen them as well, who start out with PVH and turn out to have an element of PAH. They're sometimes mixed, and in whom we do try PAH drugs, and sometimes with success, sometimes with failure, sometimes actually aggravating the situation, making this shortness of breath worse. So there's no way to avoid it. We can't put up a sign at the doctor's office, don't let them put you on PAH drugs without a right heart cath, but I wish we could.
Well, that just concerns me with patients that, you know, you getting, like I said, overwhelmed, and there's just, you want PH awareness to spread, but you don't want patients being treated.
We want patients to be cared for by physicians who have a commitment to and a passion for pulmonary hypertension.
You know, I would also add, you know, I agree, we want pH awareness to go up, just like we want a skin cancer awareness to go up, breast cancer with mammography, right, skin surveys, things like that. We don't want to miss these things. But I got to tell you, if somebody walked into my office and said, "Hi, I have cancer, can you please treat me?" I would ship them out of my office so quickly because I'm not an oncologist. The thought that I would start to treat that patient with chemotherapy and hope for the best. And if you take a step back for a second and think of PAH in some respects analogously to a blood vessel type cancer involving the pulmonary vessels, it really should be in the hands of super specialists who this is literally what they've committed their careers to treating, this PAH condition, and start treating it. But as you absolutely correctly stated, there are some very interesting data. In fact, if you simply look at discharge diagnoses from hospitals just several years ago, pulmonary hypertension, according to the discharge diagnoses, went up. 200,000 more people all of a sudden had pulmonary hypertension. They didn't have PAH, most of them, but as you mentioned, the ease of things like echocardiography and what we call Doppler echo, which can show a high pressure, and then you say they have pulmonary hypertension, and the ease of prescribing a pill in the office is easy too. It starts to happen a lot. So we all probably see a fair amount of that in our practice. But as Dr. Engel said, when they do come to you, it's wonderful when you can actually tell the patient perhaps they do not have PAH, and then second of all, you do want to hold on to them. It doesn't overwhelm many of us because you want to now be able to rearrange their treatment plan, and why send them back somewhere where maybe there was some things that were done that maybe shouldn't have been done. So.
And we do the same thing in our practice as well. Because if you remember that big pie, that's all comers of PH, 78.8% is pulmonary venous hypertension. 4-point-something% is PAH. So we love when we see PAH patients because that's why we're here. But I work with a cardiologist, so we turn no one away. Often we see patients who come in who are on PAH therapy, but really do have left heart disease. And we'll say, are you feeling better since you're on drug A? No, not really. Actually, I feel worse. So we just, work with getting some drugs off, maybe changing some other things. But we do continue to see them in our practice. It might be with recommendations to their local cardiologist, but we will see them back maybe every 6 months or so. So we keep them.
Can I ask another question? Is anybody else waiting? This is a totally different topic. We're back to exercise now. With a stable patient on therapy, I'm speaking personal, but not asking for medical advice. I'm concerned with my son's exercise with weightlifting. He's a 20-ish year old that he's very stable and he's doing a lot of heavy weights, and I'm concerned about that, and I know I'm letting him have his conversations with his physician, but what's your opinion on that, if that's a risk or okay if they tolerate it?
The question is there any benefit from isometric exercise? And I'm not aware of any data that suggests that there is. I think that when we prescribe exercise, it's cardiovascular type exercise, aerobic exercise, and not weightlifting. I generally tell patients to shy away from it because it offers no particular benefit.
Although I guess when you're in your 20s, the chicks dig it, and so there are some benefits, right? So I could at least relate to your son's predicament to some extent. But to keep it a little bit more serious, I totally agree. I don't know that there are any known medical benefits of isometric exercise or weightlifting. I do think that if a patient's condition were to progress, you actually do have to be careful with the type of strain that you can be doing with that kind of physical exercise. But I have a lot of patients ask me about lifting weights, and just like I sort of tell them about exercise, I certainly don't have a problem, again, if they want to take those very low weight dumbbells and do some general toning type exercises and helps them keep fit and their bodies tell them that it's okay. But those heavy weightlifters that are bouncing the barbell off their chest and things like that, I think you gotta be careful.
How often should you get a right heart cath? Is there should you get it every 6 months, every year, every 2 years, 5 years?
Every 5 years we come up with guidelines for the treatment of pulmonary arterial hypertension, and that's one area that is never covered in the guidelines. We all agree that at the outset, the patient should have right heart catheterization. I don't think there's any disagreement with that at all. But then when it comes to the frequency of repeat right heart catheterization, it's what's called center-specific. In other words, one center does it this way, another does it another way. Personally, I'm uncomfortable letting a patient go more than a year without a repeat right heart catheterization if I'm treating them for pulmonary arterial hypertension. And if the patient is getting worse, if the patient is becoming more dyspneic, short of breath, then we'll go right ahead and do it then and there. I've repeated right heart catheterization as quickly as within 8 days of the onset of therapy, but that was a special situation. And everybody does it differently. You know, it's kind of interesting, the pulmonary venous hypertension, when you repeat the right heart catheterization after treatment with diuretics and something we haven't mentioned, dietary sodium restriction, which is really, really important in this condition, sometimes that wedge pressure normalizes and other elements of the right heart catheterization don't, leaving you in a situation where what has looked like PVH to begin with now looks like PAH. And that, of course, presents you with a great therapeutic dilemma. But we do it with that in mind. We want to see what's happened to things like the transpulmonary gradient and the pulmonary vascular resistance on repeat catheterization. But in all conditions, if the patient's getting worse, we'll always repeat right heart catheterization. But let me ask the other panelists.
Well, I particularly agree with that point of change in clinical status. So I think that if you make the diagnosis with a combination of the right heart cath and other parameters, you put the patient on therapy, and the patient starts to do really, really well, and you're seeing them back in the office, depending on really what you would be looking for. And I do right heart catheterizations several times a week, so I actually enjoy doing them for the information that they provide in the right circumstance. I don't routinely repeat right heart catheterizations in someone with diastolic heart failure according to any set schedule. I think a history of physical examination and careful hands and some other things can continue to make you feel comfortable that patient status is doing okay. But I think if there's any confusion, the patient suddenly feels more dyspneic, there's something that seems inconsistent with some other testing, I think, as I mentioned at the very outset, sort of the stakes are too high to be guessing at what may or may not be going on. So in that instance, I will often have the patient come back to the cath lab and let's just measure these pressures directly. You can do provocative maneuvers there if you have to, whether it be giving fluid or exercise and things like that. So,
Yeah, and I would say the same thing. For right heart cath patients for IPH, we do at least, we do them yearly. And again, we would do them sooner if the patient has any change in their symptoms, or if we've initiated therapy and we really want to see response to therapy. Patients with pulmonary venous hypertension, I would just echo what both of the doctors said. We always have to watch how you're doing. And we look at other things as well. Certainly, how are you feeling? Your 6-minute walk test, what does your blood work look like? There's a lot of other things that we evaluate that tell us, well, maybe it's time to move toward a left heart cath in you. So it's very patient dependent.
Yes, I've heard this called a lesser version of PH. Is it just as serious as the PAH? Is outcomes the same? And I was also curious, can you have left diastolic dysfunction and still have PAH?
Well, yeah, so the last question, absolutely, you can have left heart dysfunction and have PAH, and we've seen many patients who have. To call this a lesser form of PH probably refers to the prognosis. I think it's not, in my experience, that this is not as a progressive disorder as PAH is, and so the survival is better untreated. But as I mentioned earlier, it's not lesser in terms of the physical abilities and functional capacity of the patient, still very, very limited, just as limited in PVH as in PAH.
I've just been diagnosed this year, so what should I be looking for?
You've just been diagnosed with PH?
I was diagnosed in April.
I'm sorry?
I was diagnosed in April.
With PAH?
With PH.
With PH, based on an echo, a right heart cath?
They told me it was based on I have sleep apnea. They think that's where it's coming from. That's all they've ever told me about it.
Do you have a lot of trouble with breathing?
Yes.
Have you had a right heart catheterization?
No.
Okay, well, that's what you're looking for. Well, my read on sleep apnea is that, yes, it is associated with pulmonary hypertension, but no, it's not associated with severe pulmonary hypertension or severe daytime symptoms other than somnolence. So I often caution physicians to be wary of the diagnosis of PH secondary to sleep apnea, especially if it seems to be severe PH. It's unlikely to be only because of sleep apnea. That doesn't mean you shouldn't get your sleep apnea treated, but it does mean you need a right heart catheterization done, as we've been talking about.
I don't have a question. I just wanted to make a comment real quick. My husband, when he was diagnosed back in 1996, he had an ejection fraction of 15%, and they were looking at putting him on the heart transplant list. Every doctor that came in told him he wasn't to do anything to stress his heart at all. One doctor came in and said, "You've damaged a whole lot of your heart, but there are some good parts of it. And if you will start walking a few steps every day and keep increasing it, you can build your heart back up." Well, his ejection fraction went from 15 up to 40-something, and then down through the years, it's dropped back down. But he walked, he did. And to this day, the two of us will go out in the desert and metal detect and stuff like that. We just refuse to quit living.
Perfect.
Thank you for the comments. Unless there are other burning questions. Oh, there is one burning in the front row.
I guess I get confused with the specialties of the doctors because I go to a PH specialist and I'm very satisfied with him. He has just ordered another right heart cath for me because in an echo it showed a little bit of elevation. He wants to check that out. And then I know that the cardiologist will be doing that. How does that all fit together? I mean, the cardiologist, I'm sure, issues just a report with what they find. And then the PH specialist would make a diagnosis? Or if it more involves the heart, I
wish that had been the first question instead of the last question. It's such a crucially important question to my mind. I think last I heard, 2/3 of patients with PAH in this country are being treated by pulmonologists, lung specialists. Now, this is a little controversial, but I've always thought of this disease as a heart disease. It's a disease of the heart and blood vessels. The blood vessels in the lungs, and it has its effects on the right side of the heart, as we've talked about. The lung tissue itself, the lung function is normal. Somehow it's fallen into the purview of pulmonologists for some reason. And this question you raise is extraordinarily important because most of the pulmonologists who treat the disease don't do the right heart catheterizations and are given a piece of paper with some numbers on it that they have to make a judgment on the basis of. And those numbers may be right or wrong because the cardiologist who's doing the procedure may or may not be interested in this field or experienced in this field. And that's why I think it's really important to, for the most part, and again, I don't want to rouse any controversy, but I think this is a disease that should be treated more by cardiologists. Cardiologists need to take a greater interest. All of us are associated with cardiologists. We are cardiologists or work for them. And I think there should be more of us in the field. Unfortunately, they're not all that motivated, cardiologists are, because they have other things that are more revenue generating to do than treat pulmonary hypertension. But the point you make is extremely important. How does the pulmonologist and the cardiologist, how do they interact? Is there any communication between the two of them? Does the cardiologist call the pulmonologist and say, hey, listen, this is what I think is going on? That doesn't happen for the most part. And it's a major limitation of the way we take care of this condition. Other comments?
So that's a good question for you to ask. And it's a very reasonable one to ask, are they having that conversation, rather than just looking at a piece of paper with numbers on it. So you have every right to ask that question.
It's the nature of the beast.
Yeah, the way it is.
Well, I mean, the reality in some extent is that medicine is and probably will always be a team game to some extent. I'm an expert at what I'm an expert in, but I'm also the first to tell you that I'm not an expert in the things that I'm not an expert in. And so, I send patients for a variety of procedures. I mentioned heart transplantation. I had a patient one time when they were actually going to need a heart transplant tell me, now, doc, just please promise me that you will be the one doing my heart transplant. And I looked at them in the eye and I said, actually, not only will I not be doing your heart transplant, I said, but sir,
You don't.
I said, if by chance you are on the operating room table, the anesthesia wears off, you look up and you see me, get off the table immediately, okay? Because I'm not a heart surgeon, right? So, I knew they needed a heart transplant. I sent them to my heart surgeon. The heart surgeon did a great job, handed him back to me, and took care of the patient. So we do have to all play in the sandbox together, but that coordination, that communication, and that sort of game plan that gets put together is center specific, and it's critical and crucial. So Debbie, I think your name is, I think that's a really, really important question, one that I would also echo to talk to your physicians about how they coordinate these things, because it is just super, super important. It's a great question. Yeah.
All right, thank you.
All right, this was great.
Thank you.
Thanks, everybody.
Thank you so much. Thank you. Thank you. Pleasure.